The scope of the work that I can speak to regarding public safety is connected to individuals that are living with mental illness and substance use disorders, right? That is the space by which the programs and the system reform is trying to address. Started back very early in 2015, where our county administration chartered an initiative called the Criminal Justice Behavioral Health Initiative. Health, human service, and public safety policy, data, resources, and funding around the space of people that are living, again, with mental illness and co-occurring conditions that come into contact into the criminal justice system, right? That initiative was launched because of a whole bunch of data that was showing the cycling effect of people primarily with low-level offenses, but after enough low-level offenses, you can start to pick up higher charges, more serious offenses if you don't have your mental health or substance abuse needs met, right? But on the criminal justice end, there's a lot of cycling of folks that have low-level, more like misdemeanor crimes that are often directly connected to their behavioral health condition. So I can give you some examples. So some of them would be like things like livability crimes, where a person with mental illness might be stealing or trespassing or involved in disorderly conduct. That's a criminal offense, and the disorderly conduct might be because they're causing a disturbance in a neighborhood. They might be scared, they might be delusional, they might be having, some sort of mental health crisis, and the criminal offense can kind of line up with some of those behaviors, right? And so the larger strategy, after we collected this data, looked at a whole bunch of best practices and looked at where our system was showing some pretty significant gaps. We really wanted to focus our intent around the prevention of deeper end criminal justice involvement. And so most of the strategies, most of the programs, most of the resources under this large county initiative are focused on what happens from the point of contact where a person, either they are the subject of a 911 call, or they make a 911 call, or there's a law enforcement contact. And then from there, focusing on at the front end, how do we keep them out of jail? What happens right when they're booked into the jail, the downtown jail? And then at the front end of the disposition with the court process. So, this last year, in 2019, we started looking specifically at ways that, opportunities to improve the system. And so we put some mental health professionals in different police departments. We put mental health professionals in the 911 system, in our dispatch centers. That work has been underway for about a year and a half, and it's ramped up, of course, over the last 8 months or so, where things that have been in motion for a while are starting to come together. When it comes to system reform, it's really important to remember that no single program or no single change is going to really create the kind of impact that we want. It really requires multiple interventions, multiple strategies, sort of all working collectively towards this larger vision, and to monitor that so that we can make improvements along the way. So back in 2017, the county launched a co-responder program that's a mental health professional paired with a police officer. We had those in Minneapolis police precincts. We learned a lot through that initiative. at the request of a number of suburban police departments and cities, we embedded social workers in police departments specifically, and those social workers are kind of building off some of the learnings from the co-responder model, where we're trying to tailor our approach so that we don't always have to have a police officer go with us to address somebody's mental health needs. In the embedded social worker model, we're trying to fine tune what's the right response, and we do that in conjunction with dialogue and triage with our police partners. Some a police will respond to because of particular, high public safety risk. Others, both could go out, or it could require just a mental health professional to resolve the needs of the individual just on their own, right? We also know that one of the things that's really important is that in order to prevent the next 911 call from occurring, right? We don't want to just address what's happening in the here and now. We really need to address what's happening in the here and now, but we also need to work towards stabilizing folks, primarily through getting them connected to a whole range of services. Some are mental health related, others could be related to housing or food instability, or whatever the case may be. As there's a wide range of needs that our social workers try to identify and then help bring in the support, again, so that they can prevent that cycling and that crisis call from happening again. Meanwhile, there's also a lot of work happening within 911 specifically, and we are very fortunate in Hennepin that our own sheriff's office runs a 911 dispatch center, and so we're using that dispatch center to do a pretty deep dive into the data around how many calls, how are they coded, what's the length of time that it takes to respond? Is there a fourth response? Right now we have police, fire, and EMS responding. Could we have, these calls dispatched to social workers to add on to this complement of resources that are already being deployed? There's a lot of work around community engagement. There's a lot of work around technological advances. And what we really want to be able to do is to leverage the power of the county agencies that collectively have a lot of information about people and a lot of information about resources. And we want to use that to bring the right response to the individual. And then again, to try to, maximize resources, get people the help that they need at the right level that they need, so that we don't end up with, either folks getting delayed access or getting mismatched. Sometimes people end up going to the hospital where if there were another alternative, they wouldn't have had to go to the hospital. Sometimes people end up booked in jail where really probably they need to be, involved in some sort of treatment approach. So our ability to align our data systems across these big areas can really be a powerful tool to help impact change, for folks in our community. So if we just look at it through a public safety lens, we're going to miss a whole bunch of other matrix or outcome measures that we really want to understand. And same would be true if we're looking at health or human service metrics. So it's kind of a both and. We want to make sure that in this space, that first and foremost, we have an accurate way to identify need, right? And then the next so how do we do that? And then the next matrix is, how do we create quick access to address their need? And then for whom, right? One of the things that the county is really focused on is disparity reduction. We know that historically there has been disproportionate access points for different communities, right? So I'll use an example around language barriers. It's much easier for folks that say speak English as their primary language to access and then navigate, some of these complex systems, like the mental health system, if they speak English. And so you can start to see different patterns in the data show up around who gets access and who doesn't. And so how do we create a system where access has really low barriers and it functions well for everybody, not just for some. So that's another matrix. On the health and human service side, we have typical measures around, did we get people access to intervention? Did we sustain service delivery, right? And for how long? And then what was the impact of that? So were we able to keep people out of hospitals, to keep them connected to their communities, keep them housed, keep them employed, all of those around both the clear health outcomes that we want to try to achieve, but then it's also the social determinants of health, these other related areas that can show up, especially for people that are living with mental health. So, and co-occurring conditions. On the public safety side, there's a whole other, lineup of different matrices around public safety. So, did our response cause harm to that person? Did it cause harm to somebody else? Like, did an officer get hurt or a social worker get hurt? How quickly was that response? Was it the right match response? So did we maintain public safety without, booking them into a jail in order to deliver that service? So there's a lot of like multi-dimensional matrix that we're trying to pull together. Again, our goal is to have health, human service, public safety alignment of data, policy, resources, and our funding and our services, right? So service delivery and then resources, our funding. And so we're measuring, like, how much did this cost? How much did that cost? What's a better way to use our resources? A more effective way to use our resources to help more people. That's another thing. Sometimes we'll see in our data that we have a lot of resources going to a very small number of people, and that's often because the resource type are deep end and very expensive. And we know that if we could do more preventative and earlier intervention, we could serve a lot more people for the same amount of money or less. So those, those are all the different sort of considerations that we have when it comes to system reform. Supportive housing, for sure. And the county is heavily investing in our housing strategy. But that is a really critical component of everything that you've just described, and especially for folks with mental illness and substance abuse. So there's that. The other thing that I would say is there's always a tendency to build more transitional beds. If we just had a place to put folks for a while, and really, we'd like to look at it a little differently. I would encourage us to think through, what can we do to, we do need residential interventions and congregate care settings, but there's a tendency to over rely from a system standpoint on those. And we want those touch points to be brief and infrequent. And really the more important area to focus our investments on is community-based interventions that have really low barriers, that can address really complex conditions, and in a way that is culturally responsive. I would say those three things, sort of working together in the front end of the system, will prevent the need from more hospital beds and and things like that. That said, though, there is certainly a need for supportive housing, for sure.
The term defunding the police has gotten a lot of press related to what it actually means. And do we focus on adjusting a policing budget so that we can put more money into these programs, or are there other ways to get the money that we need to do more treatment and community-based support? Can you offer what you think, where the funding tends to be coming from for the work that you're doing, and whether we see that as a long-term investment?
In the requests to use the federal funding that's related to COVID response and recovery, we were very intentional around targeting targeting funding for folks that were disproportionately impacted by COVID, um, and could change the trend around the impact of COVID for different communities, right? And so the funding that came forward is kind of springing us forward in a number of strategic priorities that we have had sort of on our docket, but haven't had the resources to kind of get us over this hump. So these resources are certainly going to push us forward in a whole variety of areas that kind of move from early childhood through adulthood. And again, remember what I said about, like, there's no single program that will just, resolve all these things. And so this is our shot to try to bring forward a whole bunch of different initiatives and programs and projects that kind of move us, in a big way and in a fast way towards where we want to head. What's our vision? The long-term fiscal plan is fairly straightforward. There are a number of services that are embodied in the request that will over time move over to Medicaid funding. There are also, though, some service types that we are hoping to test out that are sort of beyond a more medical model, beyond a more Medicaid funded model. And I'm speaking specifically to some of our culturally responsive service interventions. Our hope is that we can test out some of these things in a very real way, create an impact, show that impact to the legislature, and then seek permanent funding from that. This is also an area where there are many stakeholders that need to be contributing financially to this. So we've got federal Medicaid, that is a really important part of our strategy. We see the state as partnering with us in this. And so either through grants or through, different funding streams through the state, they're a critical player. There will likely be some property tax, county property tax that is considered in the long-term strategy. And then we also want health plans to think differently about how they serve their residents. They are a big payer in this space, as well as kind of moving again between public safety investments, health investments, and human service investments. So it really is kind of a collective consideration for, we're all in. If one of us fails, we're all going to fail. And so how do we move this kind of together? So this is where a lot of our policy work comes in, that again, tries to align health, human service, and public safety strategies. The informed response is coming from multiple sectors, and then it's brought forward through, a series of vetting, and then ultimately, our administration and our board has the authority to allocate those resources.